This is Dr. Leah Kaye at the Fertility Center of Las Vegas. If you're watching this video, I want you to first stop and ask yourself, am I sitting half naked on a wet Chuck's pad? If the answer is yes, I want you to hit pause and go ahead and put your pants on, and then you can hit play again. What we're going to talk about today are possible findings on your sonohysterogram. This is special imaging that we have you do to evaluate the inside of your uterine cavity to look for what we call uterine factor infertility. There can be a number of things that are going on inside the uterine cavity, and the best way for us to see them is to do the exam you might have just completed. We put a little catheter through the cervix, we do a vaginal ultrasound, and as we put the fluid through, we can expand the walls open and get a good look at the contour. What I'll talk about with you today are the potential things that we might have found and the options for management and next steps from here. So different things can be found inside your water ultrasound. The number one thing we probably see in the infertility world is something called endometrial polyps. These are little overgrowths of the endometrial tissue inside the uterine cavity. The tissue in our cavity that we shed when we get a period is made of these tiny glands, and their job is to grow and shed every month under the influence of our rising and dropping hormones. Every once in a while, you'll get a gland that kind of goes rogue and grows excessively, and they probably come and go for a lot of us. If you weren't trying to get pregnant or you weren't worried about what the inside of your cavity looked like, you might not even notice that they're there. Sometimes they have no symptoms at all. Sometimes they cause heavier bleeding. With enough time, it's possible that an endometrial polyp will outgrow its blood supply and shed itself. But a lot of the time, if you're here trying to get pregnant, we're a bit more proactive, and this is exactly why we do the exam you just did. When we see an endometrial polyp, don't let it scare you. It's not cancer. It's very, very common, but it can affect your implantation rates. Essentially, pregnancy rates out in the real world are cut in half when you have an endometrial polyp. So we talk about management, and that's what's going to come in another slide. Below here, though, is a picture of a water ultrasound showing a fibroid, or sorry, excuse me, a polyp right at the tip of the cavity. The next thing we'll talk about are uterine fibroids or myomas. There's a few different names for them. Fibroids can be located throughout the uterus. If they're on the outside of the uterus, depending on size, we kind of don't care. If they're in the muscle of the uterus, depending on size, we kind of don't care. But if they're inside the cavity, which is something that we call a submucosal fibroid, these we try to take out in the infertility world. The pictures I've pasted below, one of them is an image of the submucosal fibroid coming into your endometrial cavity. So here's the endometrium, the back wall of the uterus, the front wall of the uterus, and this fibroid coming in. And so we do a hysteroscopy. Again, we'll talk about what that is. Here's an image of what it looks like when we've gone in with a camera so that we can see this fibroid coming into the cavity, and we can use special instruments to resect it or take it out. And that way we can restore normal real estate for implantation moving forward. Another thing that we see not uncommonly is something called adhesions, which is a fancy way of saying scar tissue inside the uterine cavity. And we may or may not be able to see scar tissue. Sometimes what we'll see is what we call pore distension on the water ultrasound. But essentially, it can look a couple of ways. Adhesions or scar tissue is when pieces of your cavity have been stuck together. And now when we try to put our water in, it doesn't open all the way, or we can't get it to open at all. That would be pore distension. Or when it opens, we can see that there are connections from the back wall to the front wall or among the side walls. When these adhesions are bad enough, this is something we call Asherman syndrome. And people might be at a higher risk for these adhesions if they've ever had instrumentation inside the uterus before, like a previous hysteroscopy or a D&C. Sometimes I'll see them even with something as benign as an IUD in place for a while. And so people can be also more or less susceptible to forming scar tissue in this area. When we see it, what it means is that that tissue is not a good place for normal endometrium to grow over, and it makes it harder to get pregnant. So we have a surgery we do to remove those adhesions. And again, the pictures that I've pasted on this one here is a picture of a water ultrasound where you can see this connection between the front and back walls of the uterus. and the rest of the cavity is filled in normally. On this picture is a hysteroscopy with a patient who had an adhesion up near the top of her uterus. The opening of her right tube is up in this corner. This is the back wall. This is the front wall. The opening of her left tube is buried in a bit of scar tissue, and there's this band of tissue coming across the top. This patient had a very normal history. Sometimes we don't know why adhesions happen, but when we see them, we want to take care of them. Another common thing that we see is something called a uterine septum. A uterine septum is something that typically a person is born with. When your uterus forms, it's two tubes that come together, they join together in the middle, and then the connection in between reabsorbs so that you're left with a cavity that's supposed to be triangle shaped. In the case of a uterine septum, it's more like a heart or a V, depending on how deep that septum is. And in some cases, with a complete septum, it comes all the way down, and your two cavities never really get fully joined together. When we see a uterine septum, the biggest thing that we'll see as a result of these are repeat miscarriages. And so there's a clear reason to take them out as well. The images that I show here is a few water ultrasounds, and in particular, a 3D water ultrasound. In certain views, you can see the fluid coming in and going on either side of the septum. And so there's not a complete blockage. It can be possible to get pregnant in this way. But if an embryo implants on this tissue in the middle, this tissue that was supposed to reabsorb when we were in utero is fibrous. It's not very vascularized. And an embryo implanting on there might start to grow, but once it exhausts the blood supply, the limited blood supply that's available on that septate tissue, it stops growing, and we end up with typically a first trimester loss. Another view, one we commonly see on our ultrasound, it looks like what we call snake eyes. We turn on your uterus, and if we could look and lop it off the top, you see sort of what looks almost like two cavities as opposed to one cavity joined together, which is how it looks in the lower part of the uterus. Another thing that we might see on our water ultrasounds is retained tissue from previous pregnancies. Could be a full-term pregnancy and delivery, could be an early miscarriage or a termination, and it can look a lot of different ways on an ultrasound depending on how recently the pregnancy was. The images I have here, the one in the upper corner, this is a picture of a fairly recent miscarriage with retained tissue. And the lining, which is typically thin and even, looks very irregular. And there are a lot of spots where there's brighter and darker shadows. And so when we see this tissue, sometimes we try to manage it before going straight to surgery with different medications that might cause the uterus to cramp and push that tissue out. But in many cases, hysteroscopy or surgical removal of that tissue is one of the next steps. You can also see images that look less like this kind of irregular, kind of thick endometrium, more like a thin cavity with calcifications. And on your water ultrasound, calcifications turn up like bright white spots. That can be a sign of old tissue from a pregnancy long ago, where that tissue sticks around for a while, it becomes calcified, and then it almost acts like an IUD inside your uterine cavity. Those are not going to come out with any kind of medical management. We have to go in and surgically remove that. Here's a picture of a hysteroscopy with tissue retained products of conception lodged in the posterior wall. It looks kind of white and irregular. That can be red areas, and appears for a landmark the opening of this patient's left fallopian tube, so we can go in and cut that tissue out. All of these things are pretty easy to manage in most cases. This is why we do our water ultrasound early in your diagnostic evaluation, is to find these things and manage them proactively. Most of the time, the next step involves something called a hysteroscopy, usually with anesthesia. Hysteroscopy is just a fancy way of saying putting a camera, a scope, inside your uterus, or hystero. Most of the time we do it with anesthesia because it can be a little bit of a longer procedure, but it's very minimally invasive. We're usually not making any incisions. There's typically no stitches. When you're asleep, we put your feet up into stirrups. We do a speculum exam, and we have a little camera that's the size of a ballpoint pen. We can just guide it through the cervix. There's water that goes through that camera to expand the walls open, and because of the camera, we can take pictures while we're in there and give you a tour afterwards when you've recovered. Our camera has a little port where we can put tiny scissors through, and we use those scissors to cut out whatever doesn't belong inside there. Sometimes we'll also use bigger instruments, things with blades that are a bit bigger, to take out things like fibroids. Sometimes we use instruments that actually have heat or coagulation so that we can minimize bleeding while we're doing that procedure. And the extent of the surgery depends a little bit on what we find, how large it is, and how difficult it is to remove. Most of the time, our hysteroscopies are performed here in our center as an outpatient. It's one day where you're kind of off of your feet. You can't drive yourself home that day. But overall, the surgery might take anywhere from 15 to 30 minutes. Typically, you wake up, you head home 30, 45 minutes later, and you rest for the remainder of the day. And then you're back on your feet that day and at work, in many cases, the following day. So, again, this is why we look for these things proactively, as we can manage them pretty easily. And within the next menstrual cycle, you're as fertile as you were before our surgery, if not more fertile, ideally, after we've done the work we need to do. In order to get a hysteroscopy going, keep an eye out in emails for the financial team. Most of the time when we find something on our Sonohyst, the first people that are notified are your doctor and the financial team so that they can begin to quote you for a hysteroscopy. So keep an eye out for contact, and it has instructions there on how to proceed. The surgery is typically done on day 7 to 12 of your menstrual cycle. Usually that means with the following menstrual cycle, because most of the time if you're sitting here doing this exam now, you're in that window now, and it's usually too short a notice to schedule it in this cycle. Almost always you're going to have an in-person pre-op visit with your doctor prior to the hysteroscopy, usually within about a week of when it's scheduled. And at that time, we have you come in, we listen to your heart and your lungs, we go through instructions for what's going to happen during and after, as well as what to do before in preparation for your surgery. If at any point you have questions, please don't hesitate to reach out to me. You know how to reach me through a portal message. You also could reply to the email that you're going to get from the financial team, and you'll also be connected with our surgery scheduler through that email, who will also provide a lot of additional information. Alternatively, I always offer that if you'd like to speak with me first, we can always do a consult prior to hysteroscopy to review all of our other results, and then hysteroscopy would happen after that and prior to beginning any treatments that you might require. Couple of big things to know. There are some things that you can't see on a water ultrasound that can only be seen on hysteroscopy. A common example is something called chronic endometritis. That's a condition of inflammation inside the endometrium. When we see that, we treat it with prolonged antibiotics. So at your pre-op visit, we might talk about what do we do if we find that while we're doing your camera. Another thing to know is most of the time the surgery is done with us in our surgery center, but occasionally a bigger surgery might require operation at the hospital where we have privileges. That way we can get longer anesthesia. If we need to, we can do intubation. Most of the time this is done under deep sedation with just a face mask and oxygen. And sometimes at the hospital we have access to bigger instruments that can take care of more complicated cases. A lot of the time, too, we will complete the surgery with ultrasound guidance, meaning that we put an ultrasound on your belly to look at your uterus while we're performing our surgery. So we have somebody in there to assist us with that. If you have questions, make a note of them. We'll try to go over all of them at your pre-op visit, but you're also, of course, welcome to send me a question at any point in time. Otherwise, hopefully you're feeling better. Please feel free to take some ibuprofen if you're having any cramping, and we'll plan on seeing you soon for next steps.